Today, we'll go over 3 pharmacy-related updates for the month of April. We'll discuss a newly approved drug for Parkinson's disease, talk about some updates in covered nicotine replacement therapy on North Carolina Medicaid, and then go over a review of apixaban versus rivaroxaban in atrial fibrillation. Ongentys, or opicapone, was recently approved as adjunctive treatment to levodopa-carbidopa in patients with Parkinson's disease experiencing OFF episodes in between their doses of levodopa-carbidopa. Like entacapone or Comtan, it's a selective and reversible COMT inhibitor. This prevents the breakdown of levodopa, therefore extending the duration and benefit of the levodopa-carbidopa that a patient is taking. Unlike entacapone, which is dosed multiple times a day with each dose of levodopa-carbidopa, opicapone is only dosed once daily, with the general dosing being a 50 milligram tablet at bedtime. There is a dose reduction for moderate hepatic impairment. In the 2 major efficacy trials, it reduced off time by about 1 hour. You can see common side effects of COMT inhibitors below. Recently, Nicoderm CQ was picked up to be covered by North Carolina Medicaid, the brand patches. Some generic versions of Nicoderm patches were previously covered, but it was often very difficult for the pharmacies to know exactly which NDCs were covered, so it was difficult to ensure patients were going to be able to get their prescription. Now, North Carolina Medicaid is covering the brand names of all of the nicotine replacement products, so we don't have to worry about which generic NDCs may be covered if we just send prescriptions in as the brand names. With our North Carolina Medicaid patients, though, don't forget the North Carolina Quit Line. There is a grant for the Quit Line to be able to provide free patches and gum or lozenges to patients, as well as provide the longitudinal counseling that we know would be most beneficial for helping patients achieve tobacco cessation. This study was recently published in the Annals of Internal Medicine in April of 2020. The study compared the safety and efficacy of apixaban and rivaroxaban for atrial fibrillation by pulling data from a healthcare claims database. Therefore, all of the data collected was prescription claims, procedure claims, and ICD-9 and 10 codes. They looked at patients who had a new fill for apixaban and rivaroxaban, which was defined as not having a fill for a DOAC in the previous 180 days, and excluded patients with CKD5, cancer, valvular heart disease, or another indication for DOAC therapy. From available patients, they then matched patients 1-to-1 in the apixaban arm and the rivaroxaban arm through propensity matching. The primary efficacy composite outcome was composed of ischemic stroke or systemic embolism, and the primary composite safety outcome was GI bleed or intracranial hemorrhage. As this was a propensity-matched cohort, we had two arms, a rivaroxaban and a apixaban arm of equal size and very similar baseline characteristics. Average patient was a male around 70 years of age. About a fifth had a diagnosis of heart failure. Around 50 to 60% of patients, interestingly, had a CHADS-2 score of 0 or 1. Around 6% had CKD 3 or 4. Right under 1% had concurrent liver disease, around 20% were concurrent smokers, and then just under 30% had concurrent overweight or obesity. The only two clinical laboratory parameters collected and reported were creatinine and hemoglobin. Now, because they pulled this from kind of claims data as opposed to directly from electronic medical records or actively collecting this data, we only had this laboratory parameter data for about a third of patients in the two arms. At baseline, about 13% of patients were on an antiplatelet agent and 13% were on an NSAID. Right around 23% were on a proton pump inhibitor. About half of patients were on a statin at baseline, 65% were on a beta blocker, and 56% were on an ACE or an ARB. 21% were on antidepressants. This was not broken down as to whether it was serotonergic antidepressants or some of our other mechanisms of action. And about 15% were on concurrent oral steroids. There was a statistically significant reduction in the outcome of stroke or systemic embolism in the apixaban arm versus the rivaroxaban arm, with 251 events for rivaroxaban patients and 206 with apixaban patients, giving a number needed to treat of 875 patients with apixaban versus rivaroxaban to prevent one stroke or systemic embolism. However, when looking at these two components individually, there was not a statistically significant difference between the apixaban and the rivaroxaban arms. There was also a statistically significant reduction in the outcome of a GI bleed or intracranial hemorrhage when using apixaban versus rivaroxaban, this time with a number needed to treat of only 139 patients with apixaban instead of rivaroxaban to prevent one GI bleed or intracranial hemorrhage. This outcome appears to be driven by the reduction in GI bleeds. When looking specifically at the outcome of GI bleeds, we also saw a statistically significant reduction with apixaban, with the number needed to treat of 146. However, when looking specifically at intracranial hemorrhages, there was not a statistically significant difference. They also documented other bleeds, though didn't define what all went into another bleed. We also saw a reduction with apixaban versus rivaroxaban, though not to the magnitude seen with a reduction in GI bleeds. There are a couple of things we need to keep in mind when interpreting the results of this study. As it was retrospective and propensity matched, not all relevant variables may have been included when matching the two groups and when looking at the outcomes. There was a high proportion of patients with a lower CHADS-2 score of 0 or 1, and this was likely calculated through looking at ICD-9 and 10 codes that were coded for the patient, not necessarily defined by a provider caring for the patient. They reported the proportion of patients who were overweight or obese, but we're not really sure about proportions of morbidly obese patients in whom DOAC therapy may not be appropriate. Also thinking about the appropriateness of therapy, because of the data source that this data came from and not having full lab parameters or demographic parameters on our patients, we don't necessarily know if all of our DOAC agents were dosed appropriately, though have to assume with the large numbers in both arms that the impact of inappropriate dosing would be minimal, if anything at all. Finally, we know about some concomitant medicines, but because this looked at prescription claims data, we don't know anything about over-the-counter agents, such as over-the-counter aspirin or NSAIDs, or anything else that could have increased bleed risk in some patients. And then we knew some categories of concomitant prescription medicines, but not everything was included, such as other medicines with drug-drug interactions with our DOAC agents that may have affected the outcome. In conclusion, we do need some prospective controlled trials to definitively say apixaban is better than rivaroxaban, but this trial is just another body of evidence to add to the existing body of evidence that shows that apixaban may be safer and just as efficacious, if not a little bit more efficacious, for atrial fibrillation than rivaroxaban.